We
Abha,
are live.
Abha, you were sending me some email ID to which I could send. I have not got that. Which group are you putting that on?
Yes, ma'am. I'm doing, ma'am.
Okay.
And I've told Basir to do it, ma'am. Okay, ma'am.
Okay. I sent to just in case it
Sham,
would be a problem. Yeah. Otherwise, it should be okay, I think.
Shamji, are we live? Shamji?
Yes, sir. Yes, sir. It will take some time for people to join in, no?
Okay, because I was seeing that we are live, so I just
Yes,
asked
yes,
you.
yes. It's
Yeah.
okay, sir. No worries. We'll trim that part for the next set of people.
Okay. Fair.
Since Kaushik sir and Hari sir are here, I think we should start.
We can start, no? Dr. Abha?
We should start,
Yes.
yeah. Abba.
Yes, sir. Hello, sir. We'll start.
Yeah, please.
So I'll give a brief introduction. After that, I'll invite Kaushik sir for the welcome address.
Can we just delay it by another 2 minutes?
Yes, sir.
We can wait,
Because
sir.
I'll be just dropping into home.
Yes.
Not more than 2 minutes, sir.
Sure, sir.
Abha, can you please share your email ID? I got your number, but can you just share your email ID? That will be
Yes,
easier,
madam. Yes,
easier
ma'am.
for me. Yeah.
Sending, ma'am.
Yeah.
Amey has not joined.
Yeah,
Join, sir.
I'm here.
He's already there.
First.
Hello, everybody. Finally, the boss.
All right, we are live. We are live. We are live.
Just speak.
Yeah.
Good evening, sir. Good evening. I could not even fresh my. Thank you for joining. Hari sir. Priti madam, hi.
Sir, we are live, sir. Yeah. We are just waiting for Kaushik sir to log in. Yeah.
I need to take over. Unmute yourself.
So you will tell me, no, when you go live, once it
Is it
starts.
live? Is it live?
Technique.
Yeah.
Yes,
Yeah.
yes, we are live. Yeah.
Start.
So you will tell.
Abba, please start.
So a very warm good evening, everyone. And we all welcome all of you to this episode on metabolic health in adolescents. So International Adolescent Health Week was observed between October 10th to 19th, 2025. And the theme was Thriving Inside and Out, that is strengthening adolescent physical and mental health. So we know that on 14th of November, we celebrate National Children's Day, as well as the World Diabetes Day also coincide with the same day. So in observance of both the occasions today, we gather here today to discuss some of the very important topics on adolescent health. So I, Dr. Abha Moni Baro and Dr. Mohan T. Shenoy will be there throughout the session to help you out. And I request now Dr. Kaushik Pandit sir, he's the President of Endocrine Society of India, to give the welcome address. Welcome, sir.
Let me welcome. Yeah, we just put a word about Dr. Kaushik sir. He's the president of ESI. He has won fellowships from ASD as well as fellowship from ACE and FRCP. He's working as a consultant endocrinologist at Bellevue Clinic and is a research science at IPGMR. He's our president of ESI as well as been past president of other societies also. Welcome, sir. Over to you, sir.
Good evening and a warm welcome to everybody. It's indeed a proud privilege for Endocrine Society of India to collaborate and bring out this edition on adolescent health. Adolescence is a very important part of life. We all agree to that. But the ESI is more concerned because ESI is concerned of the future of the health of the Indians in this country. And it may not be an overstatement if I say that a healthy nation comes from healthy people, and healthy people comes from healthy childhood and adolescence. And with the background of so many adverse metabolic milieu in the country because of the very many reasons, environmental reasons, genetic reasons, we all are very concerned about the metabolic health of all Indians. And this is especially true in an adolescent health group. So Endocrine Society of India is intimately associated with the metabolic health of all Indians, and Endocrine Society of India is concerned about the future metabolic health of the Indians in this country. And for this, we all believe that we have to do something for the betterment of the metabolic health of the adolescents of this country right now. So it is very pertinent that Endocrine Society of India has taken a step to make the awareness of the adolescent health, metabolic health right now in this country. And I'm sure this will go a long way in sowing a seed of better health for the Indians for this country. Thank you very much.
Thank you, sir. It's very nice insight from you, sir. Coming from a very senior person like you definitely means a lot. So thank you, sir. Please continue in the meeting. It will be great to have your insights in the future part as well. So moving on, we also have with us the president, the secretary, Dr. KVS Harikumar. May I have his CV slide? He's the secretary of ESI. He has been a very good stalwart in this field, and he's consultant with vast experience. He's also served the Indian Army. So he's having a very high physical activity score as well, along with the publication index. And you can see he has won so many laurels. He's also editor-in-chief of many journals. So welcome, sir. Please, it will be great to have your insights, sir.
Good evening, everybody, and thanks to Dr. Mohan, Dr. Abha, and the Pediatric Endocrinology Task Force for conducting this in association with the Adolescent Health Association. And it's my honor and privilege to be here. We shall all see how our childhood changed in the, say, I would say last decade. What we were doing as adolescent, I'm sure none of the adolescent is doing nowadays. That is where the problem lies actually. And if we start inculcating the same things in them, I'm sure the job would be much easier for the future generations to live peacefully. What you sow, you shall reap. The same thing happens here also. And we all believe that catch them young is the key word. And we have an expert panel who are going to dwell on different topics of adolescent health and will keep the audience engaged about how best to improve the health of the adolescents, which will in turn be a good adults in future. And I wish the organizers the best of luck and everybody a happy learning exercise. Thanks to the Mohan and team for the invite. Thank you.
Thank you very much, sir. It was nice to having your words because it's important that you remember that metabolic health in adolescent is a very important milieu. We are not addressing many things. National programs are also there. So we have got a gamut of international and national speakers and lot of important inputs. So Pediatric Endocrinology Task Force is very much indebted to ESI for giving us this opportunity. And also we are aligning with like-minded organizations. The last episode in May, we aligned with the ITS, Indian Thyroid Society, to study the thyroid health in children and adolescents. And we also, in the month of October, we aligned with the Osteoporosis Society, that is the skeletal task force of ESI, to collaborate on research aspects and public awareness. So it is the third episode which we are doing in collaboration with other societies. So with today's episode, we are doing with the International Society. That itself is a great thing. We have Stalwart with us, who will be also speaking. So we have Dr. Preeti Galgali Madam from Bangalore, who is also the Vice President of the International Task. And also we have the opening remark from Dr. Mary Del Carmen Davi Cavilla. I hope the pronunciation is right. Dr. Mary is working as a pediatrician as well as public health specialist with advanced specialization in adolescent youth health and development and global health and health diplomacy. She's the president of International Association for Adolescent Health, that is IAAH. She's from Peru and she's advisor of many societies. Recently, we had the international conference in Jamaica, which had to be in a virtual mode. So definitely we have to understand that so many things we can collaborate with like-minded societies. She has actually sent us a video message. I will urge the technical team, Sham, to please play it out.
Sure, sir.
Dear colleagues and dear participants, the International Association for Adolescent Health, IAH, is a global organization dedicated to improve the health and well-being of adolescents through advocacy, research, education, and partnerships. One of its core goals is to empower adolescents and the professionals who serve them to address key health challenges, including metabolic health issues such as obesity and diabetes, which are rising public health concerns globally. By supporting evidence-based interventions, strengthening healthcare systems, and fostering community engagement, IAH plays a vital role in advancing metabolic health in adolescents, encouraging healthy lifestyle habits that prevent chronic diseases and promote lifelong well-being. Adolescence is a critical time to establish habits that influence metabolic health outcomes throughout life. Poor nutrition, physical inactivity, and detrimental behaviors during these periods increase the risk of obesity, insulin resistance, and diabetes. In alignment with IAH mission, it is essential to communicate scientific knowledge into practical clinical and public health measures that reach adolescents effectively. Promoting a balanced diet rich in fruits, vegetables, and whole grains, alongside regular daily physical activity, adequate sleep, and avoidance of harmful substances are foundational steps adolescents can take. Moreover, supporting positive mental health and stress management is critical, as psychological well-being significantly influences metabolic outcomes. In conclusion, IAH goals and efforts align closely with promoting adolescent metabolic health by fostering research, knowledge sharing, and actionable interventions. By mobilizing global networks emphasizing a life course approach to health, IAH ensures adolescents receive the necessary resources and support to thrive. Together, by adopting healthy lifestyle practices and supporting adolescent health initiatives, we contribute to a future with healthier individuals and stronger communities. My sincere congratulations to IWH and International Adolescent Health Week for the organization of this webinar, Metabolic Health in Adolescents, in observance of World Diabetes Day 2025 and National Children's Day 2025.
Thank you, madam, for that very important message. It's coming from you. It's very important. And I really appreciate your endeavor of joining us. She has a clashing webinar or she's not able to join on this episode live. So thank you, Preeti, madam, for facilitating the process. So it's great that we are doing such a early way of, we have not directly collaborated with us in many projects, but we hope this will be the start of the process. So thank you, madam, for joining us today virtually. So we'll continue with the program. So I want to introduce the topics and the theme. Communications to practice is what the theme lies in. So to take the topic further, may I welcome the next speaker, Dr. Preeti Galgali from Bangalore. May I request Dr. Abhamani to please introduce madam.
Dr. Preeti Galgali, madam. Madam is a pediatrician. She's a consultant, adolescent health specialist and pediatrician and she's the director, Bengaluru Adolescent Care and Counseling Center, and a clinical leader, Adolescent Clinic and Manipal Hospital, Bengaluru. Positions in professional organization, she's the Vice President of South Zone Indian Academy of Pediatrics 2025, and she's the Vice President-elect of South Asian International Association for Adolescent Health 2025 to 27. It is only because of Madam that today's episode and today's webinar is possible, because of Madam's support and Madam's permission. So we are very thankful to Madam today. And Madam has many numerous scientific publications, numerous scientific presentations, and numerous community programs. She is a great community worker and a leading author of various IP guidelines and on adolescent health. So, and she had co-authored so many international statements on adolescent health. So we often come across Madam in various guidelines and articles and reviews, and we give your valuable opinion on the topic that has been given to you today. Thank you. Welcome, ma'am.
Personally, also, I really appreciate Madam, because Madam is the Vice President of the IAP, and whatever task we have done with Madam, I think it's remarkable. We had a the trainers workshop in Hyderabad, which Madam helped us to organize. So thank you, Madam, for helping us grow. And I was also trained in Bangalore, though not under Madam. I was trained in Kempegowda Institute of Medical Sciences. I attended an adolescent health workshop under Madam's guidance. Thank you for taking time for us, ma'am. Over to you, ma'am.
Thank you so much. I thank Dr. Kaushik, Dr. Harikumar, Dr. Mohan, Dr. Amya, Dr. Abha, and the whole team of the Endocrine Society of India for collaborating with International Association for Adolescent Health to celebrate International Adolescent Health Week in such a meaningful way. So I look forward to more collaborations in the future. And as I share my slides, is it visible, my slides? Am I audible?
Yes, ma'am. It is coming, ma'am. Yeah, it's now here.
Okay.
Ma'am,
Yes.
Dr. Sri Nagesh also is the main person who has helped us. So Dr. Sri Nagesh is also here.
Okay, it's a pleasure to be here amongst all stalwarts, including Dr. Nagesh as well. So you've given me a very interesting topic, communicating healthy lifestyle to the adolescent, conversation as the key. And what I'm going to do is, of course, there are many techniques of conversation. I'm going to focus for the purpose of this presentation on motivational interviewing. We shall have a brief introduction today, and I hope that this will be a prelude to doing a workshop on motivational interviewing, which is really very, very essential to communicate with the adolescent. So for the purpose of this presentation, I would ask all of you to be in touch with your inner adolescent. I know the adolescents are living in an entirely different era nowadays, but we know as an adolescent what made us happy, what made us sad, what motivated us, and it is entirely the same feelings which work for these adolescents as well. Now there's a lot of research on motivational interviewing as a technique, and what has been proved by research is it is great to ensure oral dental hygiene. And we know that many causes of non-communicable diseases have an impact on oral dental hygiene, including caries and a change in the microbiota, which is now forming the foundation of the origin of all non-communicable diseases. MI also helps in adherence to therapy for chronic disorders like asthma and even diabetes. Also, MI is fantastic to push the adolescent to follow a healthy lifestyle. And why do we want to focus on adolescents? Because we know that 70% premature adult mortality and morbidity are due to behaviors and conditions that begin in adolescence. And these could be physical inactivity, drug use, unhealthy diet, unhealthy media use, poor stress management, adverse childhood experiences leading pointing out to a lot of emerging non-communicable diseases, which we all would not want them to occur, especially in our country. And on top of that is climate change, which is also creating havoc. We know that 50% of mental disorders present before 14 years of age. And I'm sure when we start doing research, we would realize that most of the non-communicable diseases itself are presenting before 14 years of age. And hence, early intervention is important for management to improve the quality of life, both in the adolescent period and also as adult. We also know nearly 1/4 of our adolescent girls are married, and more than 50% have anemia. And according to the developmental origin of adult disease hypothesis, we know that these are prone to metabolic syndrome, these IUGR babies, if they gain weight rapidly. Also, these IUGR babies are prone to develop impulse control disorders. So hence, as Dr. Maria said, we have to follow a life course approach, and adolescence is actually the age to intervene. So what I'll do in the next few minutes, where our focus is going to be on motivational interviewing, why motivational interviewing is important in adolescence, what is definition, what are the stages of behavior change, the techniques. We will put all this into action through a case discussion, and the end have a few sentences about what is the evidence base. So we are all familiar with this normal adolescence resistance. I can run a lot, but I won't. I can control my media use, but I won't. I love Netflix. I can control my dietary intake, but I love the Coke. So this is what adolescence is all about. And is it abnormal? Of course not. We know that in the adolescent period, there are bits for autonomy. They want to do things that they feel are important for them. And can we kind of tell them that healthy lifestyle adoption is important for you? Now, the challenge is on us. The onus is on us, how we convince them. We also know that the early adolescent period, there's formal logical operation. That is, they're not aware about the future consequences of their action. They have magical thinking. Oh, so doctor, you're telling me to stop smoking because I will get a heart attack at 30 years? Doctor, I'm just 14. I'm going to stop smoking in the next 1 year. Right? So that is the kind of magical thinking that they have. Then there is the identity crisis. What? No smoking? My favorite film star looks so dashing on the screen and he smokes so many cigarettes, right? So they don't know whom to follow. Is it their favorite film star, or are there non-smoking parents and teachers and doctors at home which they need to follow? So we often have to keep them risk-free during this period. And what about the brain? The brain has a highly reactive limbic system and a highly reactive reward center. They need the dopamine kick. They need an early solution to their problems, and they often, to overcome the stress, go into maladaptive coping, like sometimes drinking alcohol to cope up with stress, or going on speed driving to get that thrill out of life. And it is our challenge to give them healthy rewards in the form of music, dance, sports. So that is the challenge, and that is why behavior change in adolescence is difficult. But is it really all that difficult? Actually, adolescence is an age of opportunity, because the brain is still under development, and the healthy lifestyle adopted here tracks into adulthood. So that is what we as clinicians need to tap in, to develop that rapport with the adolescent and motivate the adolescent. Sometimes motivation would look like this in adolescence, running on the treadmill with a cake on the other side. Yeah, but this is not the ideal way in which we would like to motivate the adolescent. What do we do as clinicians? We often force them. We say, stop drinking colas because they're going to make you fat. I'm telling you, just stop it. Otherwise, you will get a stroke at a young age. And the adolescent, no, I love drinking cola. I cannot stop it. And we wrestle with them and we confront them. And what do adolescents do? Ultimately, they stop coming to us and they don't even change their lifestyle. So how should motivation look like? Motivation should look like a dance. It should be a dance in tandem with the therapist or with the clinician. It should be more about collaboration motivation. It should be enjoyable so that the motivation is really accepted by the adolescent. What do we need to do? For this, we need to understand first the definition of motivational interviewing. What does it mean? It means a collaborative, person-centered form of guiding to strengthen motivation to change. And motivation, as I said, is oxygen for life. So how are we going to collaborate? We want to collaborate because we want to move them through the stages of behavior change. So let me give you the example of birth control. So in the pre-contemplation stage, the adolescent says, I have no plans to use birth control. And when you talk to them and you tell them the advantages of using birth control when they're in a sexually intimate relationship, they say, I'm thinking about using birth control. Oh, doctor, now what you say is making sense. I will start using birth control soon. This is preparation. But what do we want them to do? We actually want them to act and then to maintain. So the way we speak to them, the way we collaborate them will push them in using birth control, and they will continue to use birth control when they are in an intimate relationship. So this is the way we want to shift them from pre-contemplation when they're not even bothered to action and maintenance. So as I've been emphasizing again and again that effective communication is very essential to build a therapeutic alliance with the adolescents, because adolescents are known to be little defiant. So what do? We make them feel very comfortable. We take their consent. We talk to them one-on-one. We express confidentiality limits and be respectful. Communication, 93% of the communication is actually non-verbal. The way our body position is, the way our eye contact is, how do we really sit by the side of the adolescent and not across the adolescent with a table in between. And what about the verbal communication? We need to address the adolescent first. And we say, follow the KISS principle. Keep it short and simple without scientific jargons. We have to use apt words, tone and pitch, open-ended questions, active listening, be empathetic, non-judgmental, and avoid moralizing or preaching. Oh, you are in a sexually intimate relationship. You are really have a bad character. The moment we even think like this, we have become judgmental, and we should not be really managing this adolescent and send them to another adolescent-friendly clinician. After all, God has given us 2 ears and 1 tongue, right? So we need to listen more and talk less. And that is the key in motivational interviewing. So a small exercise for you. I would like you to assess the non-verbal communication here in both these instances where a doctor is talking to the adolescent. And you can see for yourself, here the adolescent is so scared in the number 1 infographic, and the doctor is in a very authoritarian position. But look here, the doctor is in a very open situation here. There is no table here in between, and the adolescent is willing to talk. And that is the importance of non-verbal communication. In adolescent medicine, apart from the routine history taking, we take a detailed psychosocial history to understand the various domains of an adolescent's life. We take, through open-ended question, a history regarding home, nutrition, education, employment, activities, drugs, suicide, depression, sexuality, safety, even spirituality, screens, social media, sleep, and strengths. And this goes by a mnemonic called HEADS. I have also put up the reference of the article HEADS 3.0. I urge all of you to read this article, which is available free online. In adolescent medicine, we often need to interview the parents and even extended parents like grandparents to understand the adolescent better, and sometimes teachers and friends too. We need to do a physical examination with the chaperone. The management plan is first discussed with adolescent. We respect their autonomy, and then with their permission, we discuss the management plan with the parents. We also give anticipatory guidance. For example, they may not be sleeping, they may be already sleeping well, but then we need to ask them, how much media use do you use? And does media disturb your sleep? So there, right now, there's no problem, but we anticipate a problem and we have to guide them accordingly. Of course, motivational counseling is important to help them adopt a healthy lifestyle, and we must emphasize on annual wellness visits and completing routine immunization, especially the Tdap vaccine and the HPV vaccine, apart from other vaccines. Now, let's put what all we have learned in action. This is an 18-year-old boy with type 1 diabetes. He's a 12th standard student, and he comes to you with a fall in academic performance and erratic blood glucose levels since 3 months. So the parents say, I don't know why he's not doing well, doctor, and his blood glucose is going haywire, and his endocrinologist is really worried about him. So you as a pediatrician and an adolescent health specialist and also probably an endocrinologist decide to do a head psychosocial screening in private, offering confidentiality. So what does this adolescent tell you? He says he's very anxious for hurting his parents because his parents are not happy with his performance. He is worried about a drop in concentration. He wants to crack the IIT exam. He's also worried about the dark circles which he's getting under his eyes, and he misses meals sometimes because he has started going out with a new set of friends. And when you ask him, these new set of friends, what do you do with them? He says, I go out and I have a lot of fun in the pub. And what do you have in pub? And he confides in you and tells you that he sometimes has marijuana and alcohol. And he also had a blackout a few days ago. Previously, he could play football well, but now he can't. He starts coughing. And his girlfriend broke up with him recently because of substance use, and he drives a motorcycle. Now you can see that I have put some of this history in brown color, because these are the points which we are going to use when we give motivational counseling to this adolescent. This adolescent has a normal physical and systemic examination. So as I was talking about MI, there are a lot of mnemonics in MI. So one of the mnemonics is PACE, which is the spirit of MI. The spirit of MI is partnership, compassion, acceptance, and empowerment. You don't tell him, you know marijuana has such an adverse effect on your diabetes control. Oh no, you're such a bad boy. You do not do that. You have compassion, you accept his challenges, that friends are really important for him, and then you empower him how to deal with this issue. The MI strategy has 4 processes. One is engaging, forming a therapeutic relationship. Second is to develop and maintain a direction for change, evoke the reasons for change, and then have a commitment to change. So the reasons for change should be the adolescent's reasons, not your reasons, because you want the diabetes to be under control and he needs to stop marijuana for that. So you ask him, what is really concerning for you? And he tells you, I am concerned about marijuana use and a blackout. What if my parents come to know? And does marijuana has an effect on my memory? I'm concerned about a drop in my school performance. Important thing about MI is there are 2 principles. One is rule. Rule is again a mnemonic which starts for resist writing reflex. Hey, I'm telling you, stop marijuana immediately. So we try to put everything right immediately, as doctors. But adolescent you are not understanding his motivation. So you need to listen with empathy and you need to empower him. What you need to tell him is, hey, you want to do great in IIT, you want admission in IIT, but marijuana has an effect on the brain, on the hippocampus, and this will reduce your memory ability, right? So this is what you need to focus on, but you're very concerned about marijuana's effect on diabetes control. That will come later, because what is his goal in life, you have to go with that. Also, you should avoid arguments. And sometimes he says, doctor, I want more time to think about it. You must give him the time, keeping the windows and the doors of your clinic open. And you can also express empathy and saying, yes, you have a lot of stressors and there are other ways to deal for the stressors, and let us discuss that. So what are the micro skills? The micro skill goes by the acronym OARS, open-ended questions. How do drugs affect your life? affirmations. Hey, you're really worried about your parents. You are a caring son. And when he's talking to you, you say, you seem to be concerned about drug use. You feel that you may not get a girlfriend in future and you may need to increase your insulin dose. And the adolescent says, no, I'm not concerned about that. I'm only concerned about my performance in my exam. So what do you do next? You make a chart, pros and cons of changing and not changing, and you put it all down in black and white. What you are trying to do is that you are going to shift the balance. You are going to give him reasons for change, and these reasons for change could be poor diabetes control, academic failure, looking ugly, poor football performance, parental anger, may lose a nice girlfriend, blackouts, brain damage, road traffic accident, and drug addict for life. So this is how you're going to be talking to him so that he feels fully convinced that whatever problems he's having in life is probably because of marijuana. And then you ask him how important it is for you to change. You use a ruler and he tells you on a scale of 0 to 10, it is 9. And then you ask him, how confident are you? He says it is only 7. And you ask him, why not a 10? He says, because I don't think I will be able to lose my friends whom I love so much. They use marijuana and they may tempt me to use. Right? Then you ask him, do you want to make a change? He said, definitely, yes, I want to make a change. So then you again put it in black and white, the changes I want to make, the most important reason, the steps I plan. He says, I will go out with them, doctor, but I won't take marijuana, but I think I will be tempted. So let me look for a new set of friends who play football. And I used to enjoy playing football before. Let me go back to them. I know they will call me, but I will use some reason. My parents have told me to come back home early and not to go for parties. Doctor, is it okay to say white lies sometime? And you say, okay, that's absolutely fine. And I will know if my plan is working if I do not take marijuana over the next 1 month. So to repeat again and to summarize, the spirit of MI is all about collaboration. The principles is not to force. The micro skills is to use in a very empathetic way to make the adolescent say the change talk and commit to change. What does the research show? The research shows mixed results. But as we often say as a clinician, it may work for some, it may not work with some. But they have seen that 4 sessions of MI are as good as 25 sessions of CBT. So it is quick, it is brief, and very, very effective. This is a fantastic book written by Miller and Rolnick, and I would urge all of you to really read this book. The key here is whatever counseling you give to the adolescent should be relevant to the adolescent. Rewards, risks, roadblocks should all be identified, and this should be repeated. We need first to understand the adolescent and then be understood. We wrote this book and published it very recently. Dr. M.K.C. Nair is my teacher. This not only talks of MI, but of other counseling techniques. I can tell you that motivational interview builds a therapeutic alliance for a lifetime. This young adolescent, and you can see the date here, 27 September 2011, we have been seeing this adolescent for annual wellness visits, and now she is 24 years old and she has gone for her PhD to Denmark. So motivational interviewing is a style of talking that will build a therapeutic alliance with your patients for a lifetime and ensure a healthy lifestyle. Thank you very much.
Thank you, ma'am. I think your talk was an eye-opener, and today I, as a parent, has grown. I think I have grown. Like I will be able to deal with my son better as he is entering his adolescence. Also, adolescent distress is a very big issue nowadays. Recently, there was a 9-year-old girl in Jaipur who had committed suicide by jumping off a 4th floor. So again, it is very, very important that how we talk and how we deal with adolescent is very, very important.
Bullying was the cause there. So, we have to be very, very careful. How do we deal with this? Yeah, thank you very much, Abha. Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you, madam. And we move on to our next session. by Dr. Sunetra on Turner syndrome and an Indian experience. So welcome, Dr. Sunetra. Over to you. So Dr. Sunetra, she is the assistant professor in Department of Endocrinology, NRS Medical College, Kolkata, and a very dear friend of mine. And she has been a receiver of a number of awards. She has received the Yuva Ratna Award in 2023 for Best Research in Private Capacity, awarded by the Endocrine Society of India, and the A.V. Gandhi Award for Excellence in Endocrinology, awarded by ESI. She has numerous publications, above 40, and her research interests are on Turner syndrome. She has number of publications on Turner syndrome, and her publications are worth reading, and they are very much new concept, and we all are learning from her publications. So welcome, Sunetra, and over to you.
One more small point to add. Sunetra is an excellent singer also, and she motivates us to continue our habits in extracurricular activities. So thank you, Sunetra, for helping us to grow further. And Sunetra's publications are very good because many people have told me that listening to her, that is a very important idea because she has real world experience with Turner syndrome. And why Turner syndrome is important, she will tell us. Over to you.
Thank you so much, Dr. Abha and Dr. Shenoy. My earnest thanks to the Endocrine Society of India for providing me this opportunity to speak in such an august forum, and especially to Dr. Shenoy for letting me talk on a topic in which I have a lot of research interest and a little bit of work experience. So, of course, Turner syndrome is very, very different from the other syndromes. Definitely, it's possibly the commonest aneuploidy among adolescent girls. This is why we are discussing this today. But importantly, girls with Turners can lead an almost normal life with good quality if proper interventions are given in time. They're present to multiple specialties: endocrinologists, pediatricians, adolescent health specialists, gynecologists, obstetricians, cardiologists, and all of them have actually a lot to offer to improve their life. It's like a gold mine of research, of course. There is in the past also, in future also, because it's the first thing that showed what even partial absence of one of the inactivated X chromosome, what havoc it can do to your body. And thus it's like a sneak peek. It provides the sneak peek we require into the role of X inactivation in humans and possibly male-female differences as well. So it was first described by Dr. Turner in 1938, and the first case report from India was around 30 years later. At that time, bar body was used for diagnosis, and so this case was labeled as a genetic male. A bit of epidemiology, based on the Global Burden of Disease database, in 2021, India was the country with the highest number of Turner syndrome cases that was reported. Of course, courtesy our population size itself. But we do have some problems which are very specific in Indian subcontinent when it comes to the management of Turner syndrome. Of course, delayed presentation, the costly investigations and time-taking investigations that are required for the diagnosis of Turner syndrome, cost involved in screening for all the comorbidities as a blanket prescription for all girls, growth hormone therapy, the higher dose, the prolonged duration makes it more costly. For puberty induction and hormone replacement, again, we do not have the best recommended estrogen and progesterone preparations easily in India if you go by the guidelines. And again, Turner is increases cardiometabolic risk. South Asians are already at a higher cardiometabolic risk. So do South Asian girls with Turner syndrome have much, much higher cardiometabolic risk as compared to the other Turner syndrome? Coming first to the investigations regarding the diagnosis, we know there are very classic features of Turner, which we have to, when we have to do karyotyping, but otherwise also it is recommended for all girls with short stature or delayed puberty. Again, this is more easily said than done in a country like India. Karyotyping, we know apart from the classic X mosaic, X monosomy, there are so many other karyotypic variants of Turner: X mosaic, Y mosaic, isochromosomes, structural variants like ring chromosome, and all of these. So we, in our first published study on Turner syndrome, the heterogeneity of karyotypes in around 130 patients, we found, in contrast to the international literature, in India, isochromosomes, especially mosaic isochromosomes, were particularly common, whereas X mosaics and Y mosaics were slightly less common than the reported literature. We need to remember that there are karyotypes which may look like Turner, but are not, like distal deletions to XP22 or XQ24, Then elderly women with some degree of X monosomy mosaicism are not really Turner. Now, I say this because there have been this publication from a laboratory in India showing 348 cases of Turner. But if you look at the karyotypes they reported, they were not really Turner. So Turner's cannot be a laboratory diagnosis. It is a clinician come laboratory diagnosis, but not a lab diagnosis alone. Now, karyotype, the current gold standard for the detection of Turner, has its own set of limitations, cannot detect very low level of mosaicism, only major structural abnormalities can be detected. More importantly, it's time consuming, labor intensive, there is risk of manual errors and costly, of course. And therefore, there has been a lot of studies on the molecular cytogenetics in the diagnosis of Turner, utilizing microarray, MLPA, QFPCR. But again, these are mostly costly. And we did a study using quantitative PCR, the real-time qPCR, which is a very low-cost investigation using multiple primers on different areas of the X chromosome, some on the pseudo-autosomal regions, some on the non-pseudo-autosomal regions, and also on the Y chromosome, and found that using a combination of primers, the sensitivity and specificity for detection of Turner was pretty good. So the full text of this is under peer review, but we designed an algorithm using the cutoffs we got for many of the primers, in which we could not only very well rule out non-Turners, but also try to pinpoint the exact karyotypic variant of Turners like isochromosomes or classic Turner. And our results are slightly better than many of the other studies done using RT-PCR, possibly because we used multiple primers. Talking about the Turner stigmata, we read a lot about these during our residencies. So are they very relevant today? Of course, many of them do not have very objective defining criteria, but we need to remember some of the stigmata are related to underlying more serious disorders like webbed neck with cardiac malformations. And in a country in resource-poor settings like in India, they are still one of the things we look out for girls with short stature before we just randomly write a karyotype prescription. Just to mention, we found very some atypical stigmata like absence of, I should not call them stigmata, some skeletal defects like absence of part of the limbs or digits, which we believe could be related to shock haploinsufficiency or possibly lymphatic obstruction in utero. Now, this was an interesting study in which there was some data from India also, in which facial analysis, faces of Turner syndrome patients, when they were put into an AI-like software, was very, very accurate in diagnosing Turners, from detecting Turners amongst general population and also differentiating it from Noonan syndrome, which is a mimicker. So again, the things like this are actually important for resource-poor settings like us. Talking about the age of presentation, we know Turners could come to pediatricians with growth failure, to adolescent health specialists or endocrinologists for delayed puberty or amenorrhea, and finally to gynecologists for infertility. But this study, this was from Dr. Abha's institute. She was also possibly doing residency like I was during this time, showed that the median age of presentation in India was 18 years, and there were hardly any children with Turner syndrome. This was in 2017. So 5 years later, we did in our karyotype-phenotype correlation study on 100 plus patients, we also found the mean age of presentation was quite delayed, around 15 years, and most of them were presenting with primary amenorrhea, not with short stature, not with delayed puberty. Now, how early can we diagnose Turners? Of course, light from the prenatal period, fetal karyotyping can give us the clue, but using cell-free DNA for diagnosis of Turner syndrome, conflicting results from different studies. This was an Indian study showing of one around 1,700 prenatal samples. So Turner's was seen in only 0.4% of the cases. But given that most girls with Turner can have a normal life, and also data that showed that countries using NIPT, in them, Turner syndrome incidence fell dramatically. So this is an area of concern. How ethical is it to do prenatal diagnosis for Turner syndrome per se? Talking about karyotype-phenotype correlations, so many studies, we know there are some fixed features, more severe in classic, less severe in mosaics, isochromosomes intermediate with autoimmunity, Y chromosome virilization, hearing loss, ring chromosomes mental retardation. But overall findings are very discordant. And if we look at the guidelines all through the different ages, they focus on similar management strategy in all Turner's patients, irrespective of the karyotype. So are they still relevant? In India till 2013, if we look at, most of the studies on Turner syndrome have only focused on karyotype-phenotype correlation, and of course, classic Turner was more severe. So do we still need, even now, even in this year Resicon, I found so many abstracts on karyotype-phenotype correlation in Turner. So why does it interest people so much? Does it have no relevance at all? Apart from prognostication purpose, I should say in resource limited settings, it is still important because it's not always possible for us to screen all patients with Turner for all comorbidities. We cannot write cardiac MRI repeatedly for all our Turner patients. So monitoring strategy, and even more than that, monitoring frequency can be partly guided by the karyotype. In our study, we found again bicuspid aortic valve was more common in mosaics, and aortic coarctation only in classic Turner. In isochromosomes, apart from hypothyroidism, which we already know, conductive deafness was more common, and Y mosaics incidentally had the highest IQ. This was another interesting study by Dr. Khargavatsa. He looked at the risk of metabolic comorbidities in isochromosome XQ and did not find an increased risk for metabolic comorbidities. Coming to growth hormone, if we look at the 2024 and 2017 guidelines, the age for growth hormone therapy, they have lowered it further to as young as 2 years of age if there is growth failure, and of course at a higher dose and growth hormone deficiency. And we know younger age at initiation, longer duration, and higher dose are all determinants to better response to growth hormone. We do have Turner-specific Lyons growth charts from the Dr. Lyons data, but we also have an Indian Turner syndrome growth chart by Dr. Khadilkar et al. Based on around 113 patients, in which the mean adult height was much lesser than the international data on, not much lesser, but somewhat lesser than the international data for adult height in girls with Turner syndrome. And the height velocity was low at all ages. And this is how it looked like as compared to the IAP growth charts. And we found around 45% improvement in height SDS in Turners with growth hormone compared to an historical control of Turner girls without growth hormone. Now, talking about early therapy, this was based on the toddler Turner data, but the follow-up data of toddler Turner published in 2021. So the early treated versus early untreated, that is less than 6 years versus more than 6 years of age when growth hormones was initiated. The initial differences were there, but at adulthood, the difference in adult height was not significant. Regarding concerns of growth hormone as compared to growth hormone deficient kids, Turner's girls do have a higher risk of scoliosis, benign intracranial hypertension, SCFE, but the effects on cardiometabolic status after growth hormone initiation again yielded conflicting results. Now, in our study on the cardiometabolic risk in adolescents and young adults with Turner syndrome, we, however, found that growth hormone recipients had lower prevalence of metabolic syndrome, lower central obesity indices, lower and better body composition. But among growth hormone recipients, those with metabolic syndrome had actually had a history of delayed initiation and overall shorter duration of growth hormone therapy. So in the early stages, possibly growth hormone can enhance insulin resistance, but with prolonged treatment, progressive improvement occurs due to possibly alteration in body composition. But if growth hormone is initiated late, it's better to monitor for glycemic and other metabolic parameters. Talking about puberty induction and hormone replacement therapy, again in India, there is delayed presentation. Often amenorrhea is the presenting feature, leaving less room for oocyte cryopreservation. Many have not received growth hormone at all before that. We do not have the transdermal estradiol and good progesterone easily available. COCPs are still often used for puberty induction in many parts of the country. So if we go by the guidelines, now they have included AMH and inhibin in addition to FSH for the initiation of estradiol. And they have also added this clause that delayed diagnosis, which is quite common in us, with short stature and continued growth potential, if it is there, we could very well continue with growth hormone and low dose estradiol. But mind it, ultra low dose estradiol for high potential, that is gone, that is no longer recommended. Now, if you look at the choice of estrogen as per guidelines, transdermal comes first, then 17-beta or oral estradiol evaluated because they have better effects on BMD, uterine size, metabolic parameters. Ethinyl estradiol is not recommended unless and until we do not have anything else because of its adverse effects on BP and metabolic parameters. We cannot measure estradiol, and conjugated equine estrogens are not recommended for puberty induction for the increased risk of thromboembolism. If we look at the doses of transdermal estradiol, which we are about to give, we do have some transdermal patches in India, but they are all 50 microgram patches and we need 7 microgram, 14 microgram. So it can be cut into pieces like this. The bioavailability is pretty good, but I don't know how feasible that is for our girls with Turner syndrome. So I believe the way we are continuing with estradiol validate is good enough if you are giving at right dose. And to for that, we have evidences also comparing oral versus transdermal. Real data does not show much of differences actually. Talking about COCPs in Turner syndrome, often they are given because user-friendly, inexpensive, easily available, and also provide some contraception for those with residual ovarian function. But it may be used for HRT, but not for pubertal induction in adolescents. If at all we are giving, it should preferably contain estradiol validate and not ethinyl estradiol. And if given by adolescents, should contain at least 30 microgram of estradiol for peak bone mass that we achieve, not the 20 microgram one. Now, if you look at the guidelines, recent guidelines, they have focused on estradiol measurements and also uterine volume measurements during monitoring of estrogen therapy. And if adult height is attained, maybe we could continue a high dose estrogen for 5 years to improve the uterine volume. But data again have shown that even after age-appropriate pubertal induction, uterine dimensions are often subnormal in Turner syndrome. Now, based on after we found a chance finding that growth hormone recipients were having higher uterine volume, we decided to go with a systematic study and indeed found that growth hormone therapy has those who received growth hormone had higher uterine volume SDS and uterine length SDS as compared to growth hormone non-recipients. Of course, there are growth hormone receptors and IGF receptors on the myometrium and endometrium. So maybe this needs further studies to before we can recommend. Talking about metabolic risk differences for South Asian Turner, we know in the lifespan of Turner, the largest causes of mortality, 48%, is due to cardiovascular disease. This is what cuts their life short. And in our study on the prevalence of prediabetes in adolescents and young adults with Turner, the prevalence of prediabetes was 23%. And apart from BMI, waist circumference, and waist hip ratio, just like any other woman, these were better at predicting prediabetes in Turner syndrome. And also at their body composition, adolescents did have a higher truncal obesity and greater fat mass index, but lower lean mass index. And truncal fat percentage predicted metabolic syndrome in adolescents and young adults with Turner syndrome. So if we, what we can add to the guidelines from our findings, apart from weight, BMI, just like other South Asians, we should also measure waist circumference and waist hip ratio in all Turner patients, possibly waist height ratio as well, and consider the Turner specific cutoffs for these. Lipid profile, rather than 18 years, we should start right in adolescents. For prediabetes, maybe we could add OGTT-PPG, and monitoring, if growth hormone is started late, close monitoring of cardiometabolic risk is indicated. Another good thing in the guidelines is that cardiac MRI frequency they have reduced only if clinically indicated, unlike the previous guidelines. And they have added cardiac CT may be a reasonable alternative to MRI. Of course, lower cost, but higher radiation. So repeated thing is not possible. Again, another paper of us under review for bone health in adolescents with Turner syndrome, to just to see, they were not on estrogen or growth hormone, just to see whether Turner syndrome, because of its shocks problem, is an intrinsic cause of secondary osteoporosis. Interestingly, we found that BMD was lower, but when it was adjusted for their bone size, for their body size by BMAD or height adjusted Z scores, there were no differences between Turner syndrome versus controls. So possibly DEXA alone is not a very good marker of bone health in Turners. Now, there are a lot of novel concepts emerging in genetic basis of Turner syndrome. It's more of epigenetics because of the effect of the escape genes on not only other X chromosomal genes, but also on the autosomal genes. And two interesting studies from India, one on parental origin of X chromosome effect on Turner syndrome by, again, Dr. Khadgawat sir, showed that those who inherited the X from the maternal side had more of skeleton anomalies. Those from the paternal side had better correlation with the target height SDS, because SHOX gene is not modified on XP possibly by the paternal inherited X, but on the maternal inherited X. And another interesting study by Dr. Mathur sir and my friend Dr. Nancy showed that in Turner syndrome, as much as X chromosome, there were more copy number variations seen in autosome chromosome number 14, and that had better correlation with some of the problems with Turner syndrome. Our preliminary data on microRNA also showed upregulation and downregulation more of autosomes than X chromosomes in Turner syndrome. So Klinefelter is more common than Turner, but if we look at the number of studies till date, Klinefelters, it is around 5,000, but in Turners, it's double the number. And for the Indian subcontinent, specific problems, just one word about it. For delayed presentation, we do not have anything to do except more of awareness programs like this maybe. So growth hormone we should give as long as growth potential along with estrogen. It might have benefits on uterine volume, but with close monitoring on cardiometabolic parameters if you are initiating it late. For karyotyping, possibly molecular genetics studies like qPCR may replace it in future. For all comorbidity screening, again, maybe karyotype can help prioritize at least the frequency of screening of comorbidities. Since growth hormone therapy is costly, we might start pretty well at 6 years rather than at 2 years and continue till the recommended age. There is no role of oxandrolone or low dose or ultra low dose estrogen. Puberty induction, estradiol valerate is reasonably good alternative to transdermal estrogen, at least in our country. COCP is only for HRT, hormone replacement, not for pubertal induction in adolescents. And metabolic risk differences may exist. We may need more closer monitoring. There is a need for nationwide collaborative efforts, of course, to improve Turner's care and research avenues. I found that something like Turner Syndrome India group is there, but it is inactive since 2021. And ESI has opened this Turner Syndrome Indian registry. It is there in place for the last 3 years. Maybe we ourselves should take the initiative to put data and do more works using this registry. Thank you so much.
Excellent. Very good slides and very good content. And I think you have put the ESI registry, which is itself a good thing because the future is endocrinologists should definitely start managing and putting our data in the registry. Then only we will know that we have these many patients. So for that, we need documentation. We need to have electronic health records. We need to sensitize the public to come and see us. And we collaborate with pediatricians as well. So it's a very good insight that you have pulled us. Very good, very good. Keep it up, Sunitra. I think we'll have some discussion maybe towards after some time. So thank you for joining. Waiting for some time. Over to you, Abba. Yeah.
Yeah, listening to Sunitra was like really broadened our understanding about Turner syndrome, and it is always very soothing to hear you. So thank you, Sunitra. Moving on to our next session, that is Dr. Rajesh Moganty, and he's a consultant endocrinologist. And Dr. Rajesh will be talking about obesity in adolescent school health project, which is very, very important. And school health projects, they are being to my knowledge, I have seen that school health projects are being done by a lot of pediatricians across different schools. Even in Guwahati, I came across a group who is doing every yearly school health project where they are assessing height, weight, and BMI eye examination, and various other examinations as well. So I think Dr. Rajesh will be able to give us an idea about how to go ahead and how can we start and collaborate with school project and go ahead and improve adolescent health. Over to you, Dr. Rajesh.
Dr. Rajesh is a senior consultant working at Tanuku and
can you,
I know
technical team,
Rajesh.
can you please go back to the introduction slide? The introduction slide. Yes, kindly project the introduction slide, technical team, of Dr. Rajesh CV. Can you project Dr. Rajesh CV?
I know,
yes,
Rajesh, so I can maybe tell. Yeah. So Rajesh is a consultant endocrinologist at Rajesh Diabetes and Endocrine Center, Tanuku and Rajmundry. He's been very active in our circles. We know him, but I think he's doing more research and we should come up with his ideas. So that is why we are having here. So he's the co-founder and admin of so many websites and so many doctor-friendly websites and doctor-friendly projects. So he's running the diabetes.co.in. Then you got doctors.co.in, previously called formerly Doctors Hangout, listed in the BMJ itself, brandadoc.com. So if you don't have a website, he will help you to design a website. He has also done projects for endocrinology, like endocrinology.app, which is a project. And academically, he is very much is active as a digital coordinator of the Pediatric Endocrinology Task Force of ESI. He has got numerous publications, and he has also done as work from Andhra Pradesh. So he's a very good friend of mine. So I'm looking forward to listening from you. And Dr. Rajesh, over to you. Yeah, slides are coming. Yeah. Okay, over to you now. You are muted, so you can unmute yourself.
Thank you for the kind introduction. Thank you once again for the opportunity. I'll just quickly go through my topic, and this topic is related to adolescents. Of course, we know we have discussed a great deal of information regarding the adolescent awareness of diabetes in obesity and this thing. And I just wanted to concentrate my talk on evaluation in the obesity in the adolescents. At the same time, I need to focus on the growth charts and importance of bringing the importance of growth charts and making sure everyone should have a growth chart individually at their phone tips. And at the same time, I need to focus on the purpose of considering obesity as a chronic disease. And slides are moving. Yeah. So right now we need to see that the pediatricians and the HCPs and healthcare professionals should recognize and treat obesity as a pediatric obesity as a chronic disease characterized by excess or dysfunction of body fat, which impairs health, leading to the long-term morbidity and early mortality. Let us see the wait.
Unmute, sir.
No, but this toolbar is disturbing me. Can you? Okay. Yeah.
Continue. Again, you got muted. Yeah.
Wait. This toolbar. Yeah.
Now you can talk. You are unmuted.
Yeah, if you see the prevalence of the adolescents obesity and overweight, globally it is almost nearly about 18% of the school children has overweight and obesity, and nearly about 200 million number. It's a staggering number. I think its number is increasing, just a tip of an iceberg. And if in India, if you see the comprehensive national survey in 2016 and 18, you can see that overweight percentage of adolescents is nearly about 5%. Versus 4% of age between 5 to 9 years of children. And if we see the obesity percentage in both the groups, it's nearly about 1%. And there are Indian adolescent studies which showed because of there are a lot of different ethnic groups, there are a lot of different socioeconomic status differences in regions, practices of diet and development in different states. If you see that this percentage of overweight is nearly about 3 to 24%, and obesity is about 1.5% to 14%. And it depends upon the urbanization, increase in socioeconomic status. And relatively, this study, there are studies about 25 studies research where the previous decade from 2005 to 2001 to 2010 versus after the 2020, there is a staggering percentage of 5% increase in this, and a little bit of increase in overweight and obesity in north when compared to south of all these studies influence, and boys were having a little bit overweight when compared to girls. So and the ranges vary by criteria and definitions, and of course the burden of obesity is rising gradually. My slides are not moving. Can you listen? My slides are not moving. Can you help me?
Try once more.
Think.
You can off your video and just try.
Yeah. See, let us see the burden on the rationale of this, the rising adolescent obesity, the urbanization, and post-pandemic inertia. The COVID has kicked the percentage of rising of obesity and overweight to exponential way. And it tracks to diabetes type 2, hypertension, MASLD, and also increases the lifelong risk of all these morbidities and mortalities. And I think the main take-home message of this talk is how to encourage schools and give opportunity for teachers and also for the healthcare professionals to integrate each other in curbing this pandemic to go further and further, where the schools and OPDs are India's largest early detection of touch points. And if you see the obesity prevalence, we have already seen that about 10 to 15% of all are having overweight and obesity. Majority of the physiological obesity, if you call it exogenous obesity or physiological or whatever the names you give, it's about 98%, and only the 2% of the obesity causes are having pathological importance and causes. So we need to have a careful assessment and management of all these causes and clearly discriminate what are the physiological obesity or exogenous obesity versus pathological obesity, so that the economical burden to the middle class parents also not being unnecessarily wasted. So let us see the evaluation of adolescent obesity, because this adolescent obesity has got this topic of discussion is in between pediatric and it's just a transformation stage from pediatrics to adult obesity. So we should have an idea about right from the birth to the adolescent obesity, where adult obesity cases, where how can we identify the obesity pathologies right from the birth, and then give an appropriate testing and get a management properly to the case concerned. If you see the obesity and growth, if you see how to observe the growth and the obesity in the OPDs, if you see typical growth chart, in this growth chart, you can see that the height and the weight is in the upper centiles. So it's a typical of a nutritional or an exogenous obesity, where the weight is and the height is and the age, where you can see that weight age is more than the height age and the height age is more than the chronological age. And if you see the same pattern in the other case 2, the height of the child is just crossing the lines and going, it's just going down, and the weight is going upper and upper. So this shows that this child has got some height faltering and the weight is keep on increasing. So this is a typical of an endocrine case where weight is more than the chronological age, it is more than the height is. So one simple mantra when you're in OPD is picking up a child, the child is growing normal and height is going in the upper centiles, it is almost always a known 98% of normal case of an exogenous obesity. And if the child height is going short and plumpy child in your OPD, you should think of an endocrine cause and should be evaluated properly by concerned specialists. So this is just quick standout image for clinicians, where the image has been depicted with all the labelings of different things, where you can see from top to bottom dry and brittle hair typically in hypothyroidism, red hair with a monogenic cause of POMC mutation, especially in Caucasians. We may not pick up this kind of red hairs in our population, but it's typical in the Caucasians observation. Then almond shaped hair in Prader-Willi syndromes, and very common lipomastenia, where parents bring to our OPDs for a concern, and buried penis and micropenis in hypogonadism, and polydactyly in cases like Lawrence-Boone-Biddle syndromes, and acanthosis nigricans in insulin resistance cases, and acne and hirsutism in PCOS cases, and Cushing's having a violaceous striae. And in dyslipidemia, we can see xanthelasma, skin tags, and also the bowing of legs and limb, and slipped capital femoral epiphysis, which is a typical in obese child. And in genetic syndromes, we have to see focus on the dysmorphism and small hands and feet, and also short fingers and toes in like Prader-Willi, acromicra, and retinitis pigmentosa, eye problems, and also central obesity. So having seen any child in your OPD, observe from top to bottom, see for all these changes. If you find any clues to any developmental or pivotal changes in his growth, or in height changes in his growth, how to identify these clues and make a note of it. We can almost diagnose most of the cases in this manner. And also one thing to be noted is that Cushing's in a child is not as clear as in adults, and only most of the cases we see height faltering and short and plumpy child, where the classical signs of striae may not be seen in pediatric cases. And one more OPD red flag note, where a doctor should be very cautious that early onset obesity, typically child is presenting less than 5 years of age, and with even sometimes presenting as first 1 year, typically might be a pathological cause, and short stature with poor linear growth for age and mid-parental height, and hyperphagia, which is non-discriminatory. Child keeps eating even after having lunch, and he takes nighttime food, and if he sees other people eating, he again asks for food. That kind of non-discriminate hyperphagia and having dysmorphism, developmental delay, history of steroid intake with a lot of quack medication, and so many alternative medications are being used. Carefully monitor those, recall the medication from the patients, and to identify if there is any external steroid intake, and also pick up if there is any hypogonadism that can be a cause of any endocrine related pathologies. And having said that, we have to see the first what is obesity as per definitions. Let me make it simple. The cutoffs as per the IIPs and other societies. In India, simply less than 5 years WHO weight for length or height, and 5 to 18 years IIP 2015 BMI charts to be followed. Let me take you to some of the history where CDC charts covers 8 percentile lines, where it has got more than 85 to 95 percentile is overweight. Obesity is about 95, more than 95th percentile, and severe obesity is more than 120% of 95th percentile. And these children are from middle class American population. So there has been a upgradation from this to International Obesity Task Force cutoffs, where they have taken an idea from an adult BMI of 30 to 25 kg per meter square. They have backtracked the growth charts from adult cutoffs to the children, and it is a multinational study where these cutoffs were found to have higher levels than the CDC. And having said that, the obesity in the Indian scenario has got much more riskier for a given obese BMI levels. So I am this same concept of backtracking from 30 and 25 kg per meter square has been applied to 23 and 27 BMI in IIP growth charts, and it has also given the class 2 and class 3 also. These BMI growth charts, especially the upgraded extended IIP growth charts, can help you monitor the child, how the child is growing, at the same time see the effect of therapeutic interventions or any behavioral interventions in the child that can actually help. And we need to start applying these BMI charts to the children. And apart from BMI, we need to focus on waist circumference, which is very much important in our Indian scenario, where for a given BMI of for a child, when compared to other Western counterparts, the risk is higher, considering the central adiposity and hypertension, dyslipidemia, and hyperglycemia. And if at all for larger studies and to pick up and to pick up the cases and to find more cases for easy measurement, there is something called waist circumference also into the research, where there are some studies which correlated with hypertension in India, recent studies. So it is waist circumference is easy, and radial study you can measure, and there are data even for waist circumference and weight circumferences in Indian studies, but they need to be validated further. If you see the simple evaluation of the childhood obesity, the simple thing is observe the growth, observe the puberty, and examine the case. If the growth, puberty, and examination is normal, it's simply it's just an exogenous or physiological obesity, where we focus on the complication part, follow the lipid profiles or OGTT or SGPTs. If the growth is slow, it should be mostly an endocrine cause, and the calcium, phosphorus for pseudohypoparathyroidisms, ONDST for Cushing's, and FTH and TSH. And there is a mention of TSH, where if you see then practically the most of the cases, you see the cases coming with TSH of 6, 7, right, where they start prescribing thyroid medication. We should note that this is here the cause of obesity is not the thyroid hypothyroid, where it's an effect of an obesity where TSH is increasing. So we need not intervene here until there's an increasing trend of TSH, or there is more than TSH level of 10. And if you see like CNS insults in the history, like infections or any trauma, hypothalamic obesity should be picked up and MRI can be given. And if you see that if a child is having hyperphagia, disproportionate hyperphagia, observe the development. If the development is normal, the most common monogenic obesity causes like leptins and PCSK mutation conditions. And if it is abnormal, check for the methylation studies. Then you can rule out Prader-Willi syndrome, which is very much most common monogenic condition on the other side. And if these methylation studies are not there, not found with Prader-Willi, then observe the vision. If it is normal AHO phenotypes, if it's abnormal Alström's and large and small beetle symptoms. So simple thing is in endocrine causes, the growth is affected. In syndromic cause, the development is affected. And pubertal, if the both endocrine and syndromic causes are affected. In screening, more than obese more than 10 years, BP, fasting lipids, fasting blood sugars and OGTT, to be ILT and obstructive sleep apnea symptoms, and overweight more than 10 years, plus risk factors of high
Okay, Amma. Thyroid.
Metabolic syndrome and comorbid syndrome. In metabolic syndrome, there is no single pediatric definition, where IDF has got some clarity on 10 to 15, 10 to 16 years, base circumference of more than 90 centile, and more than or equal to two parameters like TGs of more than 150, HDL of less than 40, BP of more than 130 to 80 or 95th percentile. And if it is for less than 10 years, screen if waist circumference is more than 90th centile. And if it is more than, if the child is more than 16 years, you can follow the adult cutoffs. And especially in Indian nuance, consider more than 70th centile of waist circumference, which is which can also help in screening the metabolic syndromes. And order the given comorbidities like BP percentiles, lipids, and HbA1c in especially less than 6 years has not been validated in most of the studies. So preferably fasting blood sugars and OGTT is preferred, and polysomnography in cases of obstructive sleep apnea should be encouraged. Regarding the prevention, exclusive breastfeed for the first 0 to 6 months, and continue for, if possible, continue for 2 years, and avoid salt in the first year, and there is no added sugar in the first 2 years. Avoid junks. Junks is the one which has been highlighted in the IAP guidelines and all, where junk foods, ultra-processed foods, nutrition inappropriate foods, caffeinated, colored, carbonated foods or beverages, and sweet and sugar beverages should be avoided. And if at all, usually most of the children, when they come home, mother should not give the rasnas or any cool drinks. Should be encouraged to drink water when they are hungry, when they are thirst to drink something. So that should be encouraged. And screens, TV screens, less than 2 years it's 0. Less than 2 to 5 years, there is a guidelines that less 2 to 5 years of children, it's less than 1 hour. For 5 to 10 years, it should be less than 2 hours, and teens are minimal. So here it is 5210, a famous rule from Maine International Childhood Prevention, this thing which has been followed throughout the globe, where five vegetable or fruit servings in a day, 2 hours of TV, less than 2 hours of TV per day, and minimum of 1 hour per day exclusively physical activity, and carbonated drinks should be completely 0. Regarding the management of diet and feeding, the family-centered, it should be individualized, motivational, which we have seen clearly from previous speaker, Gagan Madam, regarding the motivation, how to motivate the children rather than not force feeding them, and give support the self-regulation. And regarding the children and adolescents, weight management, weight maintenance is most important than aggressive weight loss. That should be very much be in mind. And gradual weight loss, if it is severe obesities, where the younger kids to 0.25 to 0.5 kg per month, older adolescents up to 0.5 kg per 0.5 kg to 1 kg per week. And how to monitor the pubertal and also height velocity parallelly. And from ICMR and ICMR and National Institute of Nutrition, balanced diet and portion should be encouraged, where fruits, vegetables, grains, and proteins to be encouraged. And free sugars are less than 5% calories. And also focus on treating deficiencies like iron deficiencies in children having pica history and not having enough adequate sunlight, and monitoring about deficiencies of B12 and zinc. Especially in monogenic and obesity, syndromic obesity cases, focusing on impaired hunger and satiety, where sometimes standard counseling may not be sufficient to control their hunger. So that can actually give a clue for the patient to visit a doctor. And also you have to individualize energy, responsive feeding, days appropriate self-feeding, and also control access to food. And sometimes the caretakers who are taking care of the child may have to make them understand that this child has some pathological obesity condition where he can throw some tantrums and outbursts. Regarding the management of physical activity and exercise, you have to tailor the age preferences and fitness and socioeconomic status tailored to the age, and make sure that if you have any problems, for example, if the child is unable to walk suddenly, you have to watch out for subcapital femur epiphysis symptoms, and minimum more than 1 hour per day aerobic, and minimum of 20 minutes of resistance training at least 3 times in a week. And it has to be gradual, start with non-weight bearing and then progress and start adding the bone strengthening also, which is very much essential for prepubertal and peripubertal children. And regarding the adolescent therapeutics and after lifestyle, consider first after lifestyle and proper preventive management. Make sure that there is a concept called prevention plus of 6 months of time. Then we focus on structured weight program involving the healthcare physicians. Then the comprehensive multidisciplinary intervention. Then comes the tertiary care intervention, where there is a involvement of medication. So that is a process where step by step intervention is being to be considered in adolescent. And there are medications like liraglutide and semaglutide, and now recently the semaglutide has been approved for more than 12 years in the teen study. And also previously there is an orlistat. Still, if there is an about affordability issues, you can use orlistat, but there's symptoms like steatorrhea, cramps, and issues like fat soluble vitamins deficiencies. And overall, the careful and risk benefit monitoring has to be taken, and surgery is also an option for very severe class 2 and class 3 obesities with comorbid with complications. In very severe refractory cases, it has to be reserved for that. And you can see that there is a list of anti-obesity pharmacotherapy, a list of all the drugs which has been nicely mentioned here. So you can see that orlistat, liraglutide, semaglutide, and one quick word about octreotide here in this list, that especially in hypothalamic obesities, where craniopharyngioma, post-surgical, even they tried octreotide, who are not responsive to GLP-1 analogs. So, and also one binge eating disorders, dexamphetamine is approved for binge eating disorder. That also has to be kept in mind. And for Prader-Willi syndrome, growth hormone has been approved only for growth. So these are the things, different studies on which they are approved has been mentioned here. So coming to the part 2, what we have built for these growth charts, what we have taken an idea which we are planning to make it further and bigger with the help of ESI, is that we want to involve the teachers and supply with them some kits, standard operating procedures, and make sure that teachers are educated about how to inculcate sugar boards, which are being encouraged by CBSEs right now in the curriculums, and parent teachers meeting, nutritional talks, and making sure the campuses are having water rather than not being access to any sugary drinks or any canteens in the canteens, and metabolic health index dashboards for action. So this is an app which we developed, growthplots.com. It's been still in regular in the last process, about 80% has been completed. It's open to use. Here this dynamic growth charts and the weight chart. You can see that if you plot it, you have a login. Login access. Parents can plot their height and weight of your children, and it will be saved in their app. So these are the sugar boards. You can see how and we have also started an ESI satellite program. We involved pilot project in Nellore, a place in Andhra, where we encouraged 5 school principals to come and interact with us and help us in starting our pilot project in their school with our growth apps, to make sure this to be proposed to state government, where health is a state subject. So further, we wanted to make it national wide, and make sure the in school and training and workflow clues, the training and quality. We encourage the teachers to have minimum of 2 micro videos and checklists and audits, so the teachers can get easily access to how to measure these children and pick up monthly and 6 monthly measuring height and weight in the school. That can be if there is any faltering of height or weight, or there is any changes in their percentile lines, that app can pick up, and it can then go for the counseling and then go for the referral letter, whether it's a pediatrician or endocrinologist or physician. Then clues are the teachers can identify the hyperphagia in class, especially night eating in hostels. Teachers can pick up any students who are having disproportionate eating habits, and poor height gain or height gain versus weight, that can also be picked up by the teachers itself. And acanthosis and zoning in the day, despite he's having a good sleep at night, and poor scholastic performance. These clues can be trained to the teachers, so that they can also help in part of picking up this adolescent obesity very early in the school itself. So home and grandparents, where parents and grandparents has to have a very important energy literacy, that mother and grandmothers who have the typical habit of clean the plate attitude in myth, where children has to eat the complete food in the plate that is given to them, and they should know who cooks the food should decide who cooks decides the calories. So they should be aware of all these calories, and they should be also being educated about nutrition part during the parent teachers meetings. So these are the dashboards and governance and scale up of ideas, where we wanted to coverage flag and referral to the concerned healthcare professionals. Parental consent will be taken, minimal data, there is no ads, the app will be free of cost, it will be via the ESIs, and QC and audit will be then aligned with the state education and health. The scale up plan is about 6 months, and we pick up at least 5 to 10 schools. We go further to other districts, and then to the state pilots, and to the national level. And regarding the cost and support, the kids just stadiometers and tapes, and we take even help of corporate social responsibility for kids and training, and to the call to the action, where we understanding and adopt the growthplots.com, where measure early, flag fast, close the referral loop. So this is the call to action line. And final take home points are treat obesity as a chronic disease. Most pediatric cases are exogenous or primary, so don't unnecessarily over treat the patient, and start to plot growth chart for every obese child or growth faltering child. Then growth tools, less than 5 years use WHO weight for length or height. 5 to 18 years use IAP 2015 BMI, which includes class 2 and 3, and measure weight circumference in all the overweight and obese child. Don't overtest the hormones. Reserve endocrine worker for short stature, poor height, velocity, and other specific clues like syndromic pickups. Then comorbidity screening. Core pillars are like healthy diet, daily physical activity, reduce screen time, and family-centered and staged care involve the parents, family, school, and pediatricians and healthcare professional, and refer to the endocrine, psychology, and nutrition as needed. And thank you for the wonderful opportunity for ESI. and Endocrine Society of Andhra and Pediatric Task Force. It's just a joke where you can see. So it's not even a family family list of obesity where in the family whole people are not running. So a special thanks to Dr. Srinagesh sir and Dr. Mohan Shana sir and Dr. Ram Mohan sir for this opportunity, especially for the school health program to get a special launch in national level and an endocrine society for taking up this project. Thank you.
Thank you, Doctor. Wonderful. So it's a very interesting talk as well. So I think it's you have set the trend for us to all follow. So we'll just take some questions after the panel discussion, which will have some time. So over to Dr. Abha. Can you unmute yourself? Yeah.
Thank you, Mohan sir. Such a nice talk and such a nice initiative on school health project. So yeah, like I hope we all in every state we could implement this type of school project and do our best to improve adolescent health. So thank you so much, Dr. Rajesh. Moving on to our next session, that will be a panel discussion on adolescent diabetes, a Google to decipher. So to moderate this session, we have Dr. Sachin Mittal with us. Sir is the founder of the Care Plus Clinic and consultant endocrinologist of Fortis Hospital, Mohalli, and is a founder director of We Care at Home Health Services, a startup providing in-home health care. Founder of Sweet Diabetes. Sweet stands for Society for Welfare Education in Endocrinology, Thyroid and Diabetes Foundation. So, Sir has been sir is a recipient of a number of awards. He has received the Best Resident Award in DM Endocrinology from TNMC and Nair Hospital, Mumbai. Sir has, to his credit, the postdoctoral fellowship from the prestigious Great Ormond Street Hospital and University College of London, UK. And he has received the Best Presentation in Charaka Award in Essikan, Best Presentation Award in ISPAT Science School, and also Sir is a writer for many leading newspapers like the Tribune, the Hindustan Times, and he has multiple publications. So welcome, Sir, and over to you. We have the expert panelists here, Dr. M.V. Ram Mohan, Sir, Dr. Arun Vishwanath S, and Dr. Manoranjan Tripathi, Sir. So Doctor, can you project the panelist slide of Dr. M.V. Ram Mohan, Sir? So Dr. M.V. Ram Mohan, Sir, is a consultant endocrinologist and diabetologist of Diabetes and Endocrine Clinic, Nellore, and Apollo Specialty Hospital, Nellore, SHAR ISRO Hospital, Nellore. And welcome, Sir. And he is the EC member of Endocrine Society and has been also the present EC member of Indian Thyroid Society. Welcome. Next slide, Dr. Arun Vishwanath S, Sir, and Sir is a consultant endocrinologist from Tamil Nadu, and he is in areas of interest like diabetes in young, metabolic bone disorders, and adrenals, and he has multiple publications, and he has a very good knowledge on pediatric endocrinology and adolescent. Next slide. Our third expert panelist is Dr. Manoranjan Tripathi. He's a senior consultant endocrinologist, SUM Ultimate Medicare, and he's a speaker in multiple national forums, has numerous publications to his credits, author of multiple chapters, and won multiple prizes during paper and poster presentation. So welcome all of you, and over to you, Dr. Sachin, Sir, for conducting the panel discussion.
Yeah.
Thank you, Dr.
The
Abha.
panel discussion is regarding adolescent diabetes, the Google to decipher. So it's a very important discussion, very relevant as well in the modern trend. Over to you, Dr. Sachin.
Right. Thank you very much, Dr. Abha. Good evening, friends. Thank you to the entire team of Endocrinology Society of India, Endocrinology Society of India Pediatric Task Force, Dr. Mohan Shenoy, and all my dear friends, Dr. Amay Joshi, Dr. M.V. Ram Mohan. So we're going to be talking about a topic that is adolescent diabetes, a Google to decipher. It actually is a topic which has increased exponentially over the period of time. You know, the prevalence of diabetes in this particular age group has increased unfortunately very rapidly over the last few years, and it continues to increase. And I remember that maybe at the time when we were doing our graduations, the diabetes in this age group was considered more or less like a type 1 diabetes. And now over a period of time, the situation has come like that many times it is more like a type 2 diabetes rather than a type 1 diabetes, though type 1 diabetes also has increased quite a lot, and both type 1 as well as type 2 diabetes are they require a special skill set in terms of lot of spending time with the patient, lot of understanding the patient, as Dr. Preeti earlier highlighted, in a non-judgmental manner, trying to support the patient. There are a number of factors which are involved in this. So we have a wonderful panel of three experts. We have Dr. M.V. Ram Mohan, Dr. Arun Vishwanath, and Dr. Manoranjan Tripathi, and we'll talk about that particular thing over a period of time. So we'll begin with Dr. Ram Mohan first. Dr. Ram Mohan, we know that diabetes and metabolic syndrome has increased, obesity and metabolic syndrome has increased over the last 1 decade and 1.5 decade. And that with that, the prevalence of type 2 diabetes has also increased. So, sometimes you get the other rare forms of diabetes also. So how do you differentiate between the type 1, type 2, and the monogenic diabetes in adolescents?
Yeah, definitely. This is a very important question of the day because these days we are getting younger and younger diabetic patients in our OPD. So mainly, typically, clinically also we can detect many of the differences in our OPD itself. Mainly, the typical age of presentation you can see, for example, for type 1 diabetes around 5 to 18 years of age. For type 2 diabetes is more than around 10 to 12 years of is with more than 12 years, and for monogenic diabetes around it is less than 25 years of age. Then coming to the onset, if you see the onset for type 2 diabetes, it is masked for many times and we don't get any pre-diabetic stage will be there, we don't notice. For type 1 diabetes, you have a flash like onset of diabetes where you can see like sudden onset in type 1 diabetes, less than 3 to 2 months of symptoms only. For monogenic also, you see it's a masked onset. And then coming to the body weight, in type 1 diabetes, most of the type 1 people are lean, insulopenic, and they don't have proper they are like looking because of the ketosis and weight loss. For type 2 diabetic in adolescents, they look obese and they have acanthosis, and commonly they do. And in monogenic also they'll be around looks around like a lean diabetes only. Then coming to the symptoms, generally in type 1 diabetes the patients present with ketosis, DKA, and precipitating factors like you have a fever, or you have some infection leading them with polyuria, polydipsia, and admitted in the hospital for ketosis and DKA. In type 2 diabetes, generally they are randomly found with for looking for acanthosis or other symptoms of obesity. Then when they check, they tend to have a pre-diabetes and diabetes. Monogenic also, they don't have go into ketosis, but you can see they also found there will be no symptoms for monogenic also. Then you have a strong family history of diabetes in type 2 diabetes people, and also in for Modi also have you have monogenic diabetes, also a strong family history. And type 1 diabetes, you don't have a proper family history, and it's like a flash diabetes. And then as I told you, ketosis and DK are very most important things in type 1 diabetes, where the patients have insulinopenia. They tend to go for early insulin start at the time of the diagnosis itself, compared to type 2 diabetes and monogenic diabetes. Mainly the insulin requirement is also plays a role in differentiating these things. In type 1 diabetes, without insulin, we can't treat the patients, and they tend to go into decay if you they skip the insulin. And in type 2 diabetes and monogenic or diabetes, these patients will have they can be treated with oral medications. So this is how, depending on the typical age, maybe onset of body weight, then symptoms, you can go for a family history if they have ketosis or decay, or if they have any requirement of insulin. Depending on these conditions, it's very easy to differentiate between these conditions. And we have many what you say new auto antibodies available as a test for type 1 diabetes, classic like IAA, IA2, zinc transporter, and GAD antibodies. There are now 4 available for less than 10,000 rupees in many of the places. So if you have any doubt of young adolescent boy coming to you, you just do antibodies test to confirm. If the antibodies are negative, go for then. Still you have a doubt, then you can go for C-peptide levels, fasting C-peptide and postprandial C-peptide levels. Or if you have a still doubt, there is no ketosis, antibodies are negative,
Right.
C-peptide is there, then you go for a genetic testing for MODY.
Right. Thank you. Thank you very much, Dr. Amamohan. So Dr. Amamohan highlighted beautifully about the differences, how we can differentiate between type 1 versus type 2 and other forms of diabetes. So, but sometimes you have a situation where you have a double diabetes phenotype. You have adolescent with the features of both insulin resistance as well as autoimmunity.
Yes.
So I'd like to ask from you, Dr. Arun, how would you approach such a situation?
Yeah, good evening, everyone. Thanks for having me. To be honest, the term double diabetes actually baffles me because technically, when we give intensive insulin therapy for a long time in a type 1 diabetes, technically we are inducing peripheral hyperinsulinemia. So eventually, most of these so-called type 1 diabetes will have some degree of insulin resistance. So, whether should we call everybody as every type 1 diabetes as double diabetes? So that is a bit baffling. But if you go by the literature, probably even though it is not explicitly mentioned, the term double diabetes probably refers to those group of patients who has insulin resistance in addition to established type 1 diabetes from the outset. So when we do come across such patient, probably one thing that we need to be aware of is that the rate of complication must be occurring at a higher rate when insulin resistance coexists with type 1 diabetes, and they must be occurring at an earlier age compared to a typical type 1 without insulin resistance. So probably we should consider screening these patients for complication as well as comorbidities, just like type 2 patients. And because in type 1, usually we wait for around 3 to 5 years before we start screening for complications. So when we do recognize this type double diabetes, probably we need to consider screening for complication, as well as actively we should seek for comorbidities when we come across such patient. From treatment point of view, when we talk about specifically lifestyle modification, apart from the usual stuff that we teach to type 1 diabetes, like carb counting and other stuff, probably we need to focus more about weight reduction, a little bit awareness about calorie management, and a slight hypocaloric diet to induce certain amount of weight loss in such patient would be helpful. And as we all know, probably increasing the fiber content as well as the protein also enhances insulin sensitivity in such individuals. And from exercise point of view, apart from the routine exercise advice that we give to this patient, probably a little bit more advice focusing on reduction of central obesity or waist circumference could go a long way in reducing insulin resistance in such patient. From a therapeutic point of view, we all know, since the patient has definitely type 1 diabetes, intensive insulin therapy remains the bedrock. But I believe most of us would have used metformin as well as even in some cases pioglitazone for addressing insulin resistance in these patients. So, probably we are living in an era of cardiorenal protection. So probably as more data flows in, we'll be
tackling
more
both
comfortable in
basically.
using in GLP-1 analog as well as SGLT2 inhibitors, pending further literature in this area.
Yeah. So I think as more literature comes, we'll be probably more wiser. But it is suffice to say that, as you highlighted earlier, that approach should be multi-pronged, trying to screen the patients early, and therapy not only the focus, should not only the insulin therapy, but other aspects of the therapy also is important. So puberty, we know in adolescence, is an integral part of adolescent age, and it's the time of turmoil for many of the adolescents. And when you put diabetes in the mix, that's an additional turmoil. And the glycemic control does go for a toss, and it becomes very difficult to manage. So how significant is the role of pubertal hormonal changes in glycemic instability? And how do you counsel the families during expectations during this phase? Dr. Manoranjan, if I can have your opinion about this.
Thank you, sir. Good evening, everyone. So, sir, we all know that during puberty, as gonadal steroid levels start rising, there occurs increased amplitude of the GH secretion, and consequently there occurs increased IGF-1 secretion also. So this GH-IGF-1 axis is predominantly responsible for the pivotal insulin resistance, and even in a highly compliant adolescent can have inadequate glycemic control during this period. In addition to this physiological insulin resistance, there also occurs behavioral resistance, in which the adolescent tries to defy the advice of the physicians or family members, and they have erratic eating habit, reduced physical activity, and they also sometimes become non-compliant to the treatment regimen or the monitoring of glycemic parameters. So taken together, all these factors, they uh, affect the glycemic status of the child, and the glycemic control becomes very difficult during this period. As physicians, as it's our duty to counsel both the parents and the adolescent regarding these normal physiological changes that occur during puberty. We should explain the parents that during puberty the hormones compete with insulin, and therefore the glycemic control becomes difficult. But we have to keep patience. We should have realistic expectations regarding the glycemic control, rather than focusing on a perfect glycemic control that is very difficult to achieve during this period. Simultaneously, we should also empower the adolescent in the management of their diabetes care, encouraging them to take the ownership, perform more frequent blood glucose monitoring, so that we can have better glycemic control by adjusting the insulin dose. In fact, all this should be done under supervision, and collaboratively, when taken together, we can achieve a better glycemic control. But simultaneously, we should remember that even with all our effort, the glycemic control can become difficult during this period, and we should not blame the adolescent or the child who is already going through a emotional turmoil regarding the poor glycemic control during this period.
Right. Thank you very much, Dr. Manoranjan. So, we discussed that how challenging diabetes is on itself, and especially in this particular age group, and how there are so many things going around which can actually complicate this. So there is one role which, one thing which we can use, that is the role of technology, and it has enhanced over a period of time, and it continues to increase more and more, and it is something which probably can lead to better outcomes for a patient. So I'd like to know from you, Dr. Upin and Dr. Rama Mohan, how best we can use technology in adolescent diabetes, and what are the barriers to its widespread use?
Definitely, we should adopt the newer technology. We should cope up with the newer technology to have a better outcomes in type 1 diabetes. After coming of CGMS, the lives of most of our type 1 diabetes, when new onset type 1 diabetes or in hospital type 1 diabetes management became very much easier with the use of CGMS, and SMBG with CGMS is become day to day. It is cheaper now, and most of our type 1 kids will be happy to use this CGMS, and they'll be happy to share their readings with the doctor to have a good glycemic control. And also having a with newer technology like having a EMR, where you get good reminders for them to come for follow-ups, and using a EMR, using CGMS, you have a app, you have a diet apps are coming. So adopting the newer technology is very, very important in adolescent people, and because as they are teenagers and pre-teenagers, they tend to have their own identity, they have their own inferiority complex in the schools, and where they need to be motivated continuously to have a good control in diabetes, because they tend to. I have a type 1 patient who stands before my OPD, sends his mom into my OPD, tells that I'll come into the OPD if sir stops my insulin, then only I'll come inside. Otherwise, I won't come in, I'll stay outside. Like that. These kids are little stubborn and little naughty, and they'll be always having a social barrier, and they'll always having a school barrier. So using technology is also very, very important. It makes their lives better.
Right. So thank you, Dr. Ramamohan. So Dr. Ramamohan raised a point about, how, there are certain situations which kids face, whether in terms of, treatment fatigue, body image issues, and, burnout. So Dr. Arun, I would like to know from you what strategies we can use for tackling these issues, whether you talk of the treatment burnout, the treatment fatigue, the body image issues, which are so common among adolescents with diabetes.
Yes, sir. I think most of the answer to this question has been highlighted by Preeti in Preeti ma'am's talk. All the emotional distress that usually we get in adolescent gets only magnified when the adolescent develop diabetes. But what we can remember is that none of these conditions develops all of a sudden. It develops over a period of time, over a period of unaddressed diabetic distress. So, as most international organizations says that probably any type of diabetes in adolescents should not be considered as a biological condition, but as a biopsychosocial condition. And if you are viewing from a clinician point of view, we are having that kind of approach. Probably we should be employing about some validated questionnaires, or at least some form of question should be posed to these patients right from the beginning, so that we could pick up these unaddressed diabetes distress or management issue right at the beginning. So once we pick up those cases at the earlier stage before they develop into a full-blown burnout or body image issues, we can easily refer them for professional help. But unfortunately, most of the time, the psychologist or the psychiatrist have very little knowledge about kids with diabetes. So that is an issue. As ma'am highlighted, probably cognitive behavioral therapy and motivational interviewing, if administered by a properly educated professional support, goes a long way in handling these patients once they do develop. But from our point of view, from clinician point of view, probably if we have a very good relationship, open, honest relationship, as ma'am showed in one of her slides, when there is a very authoritative doctor and a very fearful patient, instead of that, if you have a open relationship with patient, probably they will come out with these problem earlier. But it's easier said than done. If you're following one kid from childhood till adolescence, probably we'll have a very good rapport. But most of the time, when patient lands in adolescent, land as an adolescent in our clinic, it's very difficult to establish that kind of relationship. But again, I think if we could encourage these patients to, in a patient support group, if we could make them participate in patient support group, it goes a long way in handling these issues. For example, in my part of the part of Tamil Nadu, there is a type 1 foundation exclusively run by type 1 diabetes patient, and no doctors are involved. It has been, it has been operative for the last 2 years, and they are meeting bi-monthly, not in a very social. When they may meet in park, beaches, and other stuff, they go to movie theaters together. And after arrival of this type 1 foundation forum in my place, it has made a sea changes. Many of those difficult kids who are landing up with DK for several time after arrival of this program, it has in turn it has made a slightly difficult life easier. Slightly easier for us. And again, sharing responsibility of the patient by actively encouraging parents to participate instead of
Right.
everything being done by the patient. Probably if parents could support and split the workload
Absolutely.
of self-management, that again goes a long way
It
in
goes a
handling
long
this.
way. Thank you. Thank you so much, Dr. Arun. So it's important you highlighted the importance of patient support group, the peer support, and also, you mentioned about the importance of parents. So, families, they play a huge role when it comes to managing adolescent diabetes. So, similarly, there is another huge role which is being placed by the school. So how can families and schools be engaged effectively without making the adolescents feel different or overly monitored? Dr. Anmanoranjan, your thoughts on that?
Sir, so we all know that the adolescent value independence and they hate supervision. So during this period, by we means the physicians, the family members, and the school staffs, school teachers, and other support school staffs should act as a team. And in the center of that team, the adolescent should be placed. The family members, they should be encouraged to gradually transfer the responsibility of diabetes care towards the adolescent, definitely under supervision. Then the school teachers and other school staffs, they should be sensitized to incorporate the diabetes care, common things like doing blood sugar testing, or taking the mid-meal snacks, or taking the insulin at appropriate time. All the school teachers and school staff should be sensitized to this type of care, and they should be accepted. They should not be stigmatized, or they should not be embarrassed before the class. And for us, we physicians should we should positively reinforce what the child is doing good. We should not only find out the faults of the child or blame the child for what he is not doing. Rather than we should positively reinforce what the child is doing well, and uh, if we do all these as a team, this will help the adolescent to cope up with the emotional distress he is going through, and he will take the ownership of the condition, and it will lead to a better glycemic control and better lesser complications in the future.
Right. Thank you so much. I think we are nearly close to the end of our time, and I would like to hand over the stage back to Dr. Abha for further deliberations. Thank you so much. Thank you, Dr. Amma Mohan. Thank you, Dr. Arun Vishwanath. Thank you, Dr. Manoranjan, for your
Thank you,
kind
sir.
time, for active participation and expert opinions. And over to you, Dr. Abha.
Thank you, sir. Great discussion and a great learning session from you. And yeah, we are towards the end of the session or the webinar today. And we want to hear from Dr. Amay Joshi now. And I would request Dr. Amay Joshi, sir, to give the concluding remarks. Dr. Sachin, sir, we are very thankful to you for taking out your time and making us go through such a lively panel discussion, and your questions were really enlightening and gave us a lot of answers to the various questions that we face and the problems that we face in our day-to-day life and in our practice. Thank you, sir. So over to you, Amay Joshi, sir.
Thank you, Dr. Abha. Incidentally, you will realize that we all three are Mumbai postgrads on the pitch, you, me, and Sachin. And I remembered my residency days that I was an internist who went to endocrine, and Sachin was a pediatrician who came to endocrine. We made a very good pair, and we taught each other, we learned from each other. In our residency days, we used to send an adolescent, okay, medicine will say, pediatrics will see, pediatrics will say, medicine will see. Finally, adolescence was a turmoil, and they never wanted to be supervised. And me and Dr. Sachin also never wanted to be supervised in our residency. So I think I was actually thrilled to know when Dr. Mohan put forward this concept in our pediatric endocrine task force, because endocrinology as a whole encompasses any and every hormonal change from pregnancy to neonate to adolescent to geriatrics and an adult. And that's what makes a complete endocrinologist. We have a cluster of pediatricians and internists finally taking, learning, and becoming an endocrinologist. It was a wonderful attempt for Endocrine Society of India to reach out to IIHH. Gratitude to Dr. Galgali madam to agree for that. And then we delivered very, very well. Dr. Galgali madam spoke about communicating to an adolescent, and that's an important barrier which everyone faces alike, that how to make friends with an adolescent. I think the most important thing is learn their priorities, tune your narrative, adapting to their priorities. I think Dr. Sunetra was phenomenal in taking us through the turners. I mean, the turns in the life of a turner, the care of turner is way beyond HRT and growth hormone. I think very, very wonderful insights given by Dr. Rajesh. I think he is a man with brains, I think big brains, and may his plans materialize so that we come to know more about the growth, and maybe we are able to cater to pediatric obesity. Pick it up, sensitize, and treat them so that we have a better, healthier India. And for panel discussion, my great friend Dr. Sachin chipped in lively. We got that maybe little sense of humor from our interactions and days at Nair. I think we all learn, and as such, we all face a turmoil. Adolescence is maybe a peak, and maybe at two ends are the slopes. It was, I think, I must say that pediatric endocrine task force should do more and more adolescent-centered webinars. I think one of the best things that I listened was the webinar for today. I think we end up listening to a lot of stuff which we just want to maybe forget, maybe we don't think that it's relevant, it doesn't catch you for, but I think it was great. I was logged in for all 2 hours, and it was worth an effort. I think thank you, Dr. Mohan and Dr. Abha, for the wonderful coordination and making it happen. I hand it over to my dear friend Dr. Sri Nagesh, who taught me a lot of pediatric endocrinology for the vote of thanks.
Thank you, Ameya, and it's been a great session. Like Ameya said, we've all been locked down for the past 2 years into an excellent session. And it gives me great pleasure to give this vote of thanks. It's my privilege to deliver this vote of thanks on behalf of the Endocrine Society of India and IAH. At the outset, I extend my heartfelt gratitude to our distinguished speakers, Dr. Maria del Carmen Caye Davila, Dr. Preeti Galgali, who has kept us engaged in a spellbound manner for the past 1 hour with excellent insights. This has been an education for all of us today. We've heard a lot about ma'am all these days, and it's one of the first times that we've seen her in a co-endocrine session, endocrine and adolescent session, and it's been really worth it. This is really one of the highlight sessions of this year. Dr. Sunetra Mondal, who's been a very active part of all our endocrine activities, and Dr. Rajesh Moganti, one of our tech barons, for their insightful talks that have beautifully bridged the adolescent communication, as well as the endocrine realities and the public health perspectives in this area. A special note of appreciation to my dear friend and batchmate Sachin Mittal and the expert panelists M.B. Rammohan, Arun Vishwanath, one of the rising stars in Endocrine Society, and Manoranjan Tripathi, who's been a very active part of the pediatric endocrine task force, for this engaging discussion, which has actually added real clinical value to everybody who's logged in into this program. Our sincere thanks to our esteemed President, Dr. Kaushik Pandit sir, and our Secretary KVS Harikumar, for their inspiring leadership and for giving us this opportunity and being very accommodating with all our requests with regard to this workshop. And to our host, the ever-active Mohan Shenoy, who's the leading light behind the Pediatric Endocrine Task Force, and Abha Mani, who's done an excellent job taking hold of the session, and she set a perfect tone for the session. I also would like to gratefully acknowledge the ESI Pediatric Endocrinology Task Force led by my dear friend Ameya, H.K. Ganesh, a senior endocrinologist, and also Mohan Shenoy, who is the coordinator and the boss of the Pediatric Endocrine Task Force, for conceptualizing and scientifically coordinating this program. Mohan has done many good programs under the Endocrine Society Pediatric Endocrine Task Force, and we hope there'll be more such programs and a lot of international collaborations. This is actually a very big day for us, given the fact that we've had a collaboration and a joint workshop with IAH. And this is especially relevant given the fact that this is done on the occasion of the World Diabetes Day and National Children's Day 2025. And most important, this conference and this seminar would have been nothing without the participants. So a big thank you to all the participants across India and beyond. Your presence and your trust in us reinforces our shared commitment to protecting adolescent health and nurturing healthier futures. Thank you one and all, and good night.
Thank you, sir. Thank you, madam.
Thank you very much.
Thank you. Thank you, everyone. Good night. Bye-bye.
Thank you, technical team.
Thank you. Bye-bye.
Thank you, video.
Thank you. Thank you, Mohan
Thank you,
bhai.
sir. Good night, sir.
घर पहुंचे कि नहीं?
Technical team.
Yes.
Thank you.
Bashir.
I think
Thanks
it was great.
Bashir also did a great job. Kaushik bhai is here. Kaushik Vishwas. Thank you. Thank you, Suneta. Thank you, Abha.
Thank you,
Bye-bye.
sir. Mohan, sir.
Stay safe. Bye-bye.